Margo. My name is Nicky Davies and I'm the Adult Services Officer at Clapper.
And I'm Kenny Ardwin and I'm the Adult Services Coordinator. Together we make up Clapper's Adult Service Delivery team.
Welcome to this month's Cleft Talk panel discussion brought to you by Clapper's Adult Services Project, proudly supported by the VTCT Foundation.
Cleft Talk is your opportunity to learn more about the topics that adults born with a cleft across the UK told us are important to them through the Adult Survey and Roadshow.
We hope that you find our panel discussions both entertaining and informative. Remember that you can keep up with the Adult Services Project online, including watching or listening to this and other panel discussions again at www.clapper.com/adultservicesproject. You also can join the conversation on Facebook at www.facebook.com/groups/clapperadults.
This month on the programme we're discussing a topic that becomes of interest to many adults as they start to settle down a bit: genetics and decision making around having children. Our focus groups and 2018 survey showed that this was a topic people were very interested in, but perhaps didn't know an awful lot about.
Today we hope to provide you with some information so that you feel better informed about some of the genetic factors of cleft, as well as the services available to you when you're thinking about starting a family.
It is our pleasure to welcome our marvellous panel guests, Jess, Hare, clinical psychologist, and Margo, Whiteford, former geneticist in the Scotland Cleft Service. Can you please start by telling us a bit about yourselves and your background? I'll start with you, Margo.
Well, as you said, I'm Margo Whiteford and I'm a very recently retired consultant clinical geneticist. I started working for the Cleft team in the west of Scotland way back in 1996. So I've got about 23 years experience of seeing mainly children with clefts, but obviously some of these children are now adults, so I've seen them back at the genetics clinic to discuss the sort of questions that you're wanting to discuss today.
Excellent. Well, we're very grateful to you for coming out of retirement to join us. So thank you.
And as you said, I'm Jess Hare and I'm one of two clinical psychologists who work in the Cleft team here in Scotland, and I've been here for the past 2.5 years, and before that I was in the East of England Cleft team down in Cambridge, and Cleft is the only area I've ever worked in since qualifying as a clinical psychologist.
Excellent. A pleasure as always to have you, Jess.
Thank you.
Okay, so this first one's for you, Margo. Genetics is such a big topic. This can be hard to know where to start, but can you please give us an overview of what genetics are?
It is a big subject, yes, and it's really getting bigger all the time. Basically, our genes are the inherited factors that get passed from generation to generation, that they're basically instructions or recipes about how the body's to form in the first instance when it's developing in the womb, how it functions and grows as we go out throughout life, and things like our brown hair and our blue eyes and such like. But as I say, a lot of the genes are working straight after conception to make sure that all the parts of the body arrive in the right place at the right time. And it's not just one gene for each of these functions, it's usually multiple genes that are involved, and it's all very complex.
Now, some of us will be able to remember back a little bit to biology class, and we'll recall terms like autosomal dominant, autosomal recessive, X-linked genes and the like. Can you briefly explain the various ways in which a gene can be passed to our children?
You're quite right in remembering back to biology and these terms, but of course not everybody does biology at school.
I don't remember that.
These will be completely foreign words. So basically, all of our genes come in pairs, because we get one from mum and one from dad of each of the pairs of genes. And some medical problems arise if only one of the pair of the genes is altered in some way, whereas other medical problems only arise if both the copies of a pair of genes have got an alteration in them. So the autosomal dominant that you mentioned, that's when only one of the pair of genes is altered and gets passed down from parent to child to the next generation, whereas recessive is the one where both copies of a pair of genes need to be altered in some way. And in that situation, the mum and dad are completely healthy, they don't have any medical problems, but they've got one altered copy of the gene and one normal copy of the gene. But obviously they both pass on their altered copy of the gene. The child has then two altered copies and no normal copy of the gene to compensate. And with that type of inheritance, we tend to see the medical problems only in one generation of the family, because even if the child has got the two altered copies, when they grow up and have a partner, their partner's likely to have two normal copies of that gene, and therefore their children will not be affected. The X-linked one's a strange one. Again, some people who have done biology will remember that males have one X and one Y chromosome, which is what makes them male, whereas females have two X chromosomes. So if there's an altered gene on the X chromosome, it tends to affect males rather than females, because the female's got their second copy of that gene on their other X chromosome. So again, the way that that's inherited, quite often the mother will be unaffected by the medical problem, even though she's got the altered gene on the X chromosome. That if she passes it on to a boy, he will be affected by the condition. That if she passes it on to a girl, that girl will be a healthy carrier of the altered gene, just like her mom.
Well, thank you for that explanation, because I think it can be quite confusing sometimes to figure out, why there might be an isolated case of something within a family, but I think that helps us begin to understand some of the things that can happen and just how complex.
And sometimes the gene becomes altered as it's passed on, so there's been nobody else in the family with the condition before them, but then once that altered gene's passed on, it can then go down the generations of the family.
We often hear that cleft is a combination of genetic and environmental factors coming together. When it exceeds a threshold, a cleft occurs. Can you do your best to explain in lay terms this threshold theory?
Well, like I was saying earlier, it's probably multiple genes which need to be altered before somebody is even susceptible to a cleft occurring. So they will have inherited these multiple genes probably from both parents, and that makes them susceptible to a cleft, but something else has to happen during the pregnancy before the cleft will actually occur. So there'll be some babies who have the susceptibility, who are never exposed to the environmental factors and they're fine, and there'll be other babies who are exposed to the environmental factors, but because they haven't got the susceptibility genes, they don't develop a cleft. So it's only that group in the middle that have got both the susceptibility genes and are exposed to the environmental factors that will actually be affected by a cleft.
Makes a lot of sense, and obviously we don't have control over our genetics. To some extent we may have some control over some of the environmental contributors to cleft. So to that end, can you please explain what the environmental or the known environmental factors for cleft are, and if there's anything that people can do to reduce the likelihood of their child having a cleft, and if so, at what point you recommend they do it?
We don't know an awful lot about either the genetic or the environmental factors involved in clefts occurring. We do know some of the environmental factors, like ladies who are insulin-dependent diabetics have got a higher risk of having a baby with a cleft. Similarly, ladies who have epilepsy and have to take certain anti-epileptic medications have got an increased risk of having a baby with a cleft. And in these situations, the lady with diabetes, if she sees her diabetic consultant and gets her control as good as possible prior to trying for a pregnancy, that would be important. And the ladies with epilepsy, if they see their epileptic consultant, and it may well be that they get changed on to another medication prior to a pregnancy, or they may be reassured that the medication that they're on is one of the ones that's less likely to cause any problems. For other kind of problems that occur in newborn babies, we know about vitamins being involved, and there has been various theories that might be involved in clefts as well, but none of the studies have proven that conclusively at the moment. But we would suggest that any mother trying for a pregnancy takes folic acid to prevent other things like spina bifida occurring in the baby, and also the multivitamin tablet that's recommended for all pregnant women. And also just leading a healthy lifestyle, having a good balanced diet, getting exercise and fresh air, and just being as healthy as possible before trying for a pregnancy.
Does that go for the men as well?
It's not quite so important for the men, unfortunately. We can't say that because they don't actually carry the baby, so it's not so important. So men with epilepsy and diabetes don't have an increased risk of having a baby with a cleft.
Damn inequality.
I know.
If I was born with a cleft myself, is my child more likely to be born with a cleft than someone who has no history of cleft?
Unfortunately, yes. And again, that's because we know that genetic factors are involved, probably in some people and not in others, but because we can't pick out these people who have the genetic factors and those that don't, then we have to say to everybody who has a cleft that they would have an increased chance. So in most kind of developed countries' population, the chance of having a baby with a cleft lip, with or without a cleft palate, is about 1 in 700. And those having a baby with an isolated cleft palate, about 1 in 1500. It's a bit less common. So for somebody who's already got a cleft themselves, these figures change quite dramatically actually, and it goes up to a 1 in 50 chance. So of 50 couples where one of them's got a cleft, their chance of having a baby with a cleft is about 1 chance in 50. One of these couples would have a baby with a cleft. I quite often turn that round the other way and say that 49 out of the 50 are not going to have a baby with a cleft, and it sounds much more reassuring that way. So it's still a low risk 1 in 50, although it's higher than the population is.
I remember there was a patient I'd referred to you once, and I think one of the things that you said that was quite helpful to them was that you'd also compared that to the likelihood of having any kind of health condition. Could you remind me what those statistics were?
That's true, and I think if most people knew what the risks were before they had babies, less people would be having babies. If we took 100 couples with no health problems in their family, then the likelihood of them having a baby with a severe medical problem would be that 2 or 3 out of that 100 would have a baby with a severe medical problem. So that kind of 1 in 50 is actually 2 in 100, so it's similar to the chance of having a baby with some sort of medical problem.
And obviously, it's a really interesting one in our community of adults who are thinking about having children, because obviously cleft is very much front and centre of their mind. But you're exactly right. There's so many other things, and because we haven't got that direct connection with, we don't think about, we don't worry about.
Yeah.
It's a lottery for everyone.
Yeah,
that's right.
Absolutely. Now, one of the things that we know frustrates people is that there's a lot of different statistics that are often quoted out there for the chance of having a child be born with a cleft. I mean, we see them on our Facebook page all the time, all sorts of different things. And obviously that 1 in 50 is a good benchmark. But where can people go to get the best genetic information that's bespoke to them?
I mean, you will see variable figures, because the way that these figures are found are by population studies. So one population is going to be slightly different from another population, and that's why I said in most developed countries these are the statistics. In fact, in Scotland, instead of it being a 1 in 1,500 risk for having a child with an isolated cleft, it's actually nearer to the 1 in 700 figure of cleft lip and palate, so it does vary from population to population. And I guess if it's statistics that you're wanting, you should ask to be referred to your local cleft team, and perhaps onwards to the genetic clinic if there's not a geneticist attached to the cleft team itself.
What is genetic counselling, and how do people access it?
Your GP can refer you to a genetics clinic, or if you're part of a cleft clinic, they can refer you, or any other hospital consultant can refer. Some genetics clinics do take self-referrals. We used to in Glasgow, but not so much now. If people phone up, we say, if you go along to your GP, I'm sure he'll send in an official referral letter. So when people come along to a genetics clinic, what we start by doing is drawing a family tree. Because although they're there to discuss the one medical problem they've got, as we draw the family tree, we might see other things that give us clues to what might be going on in a family. Not necessarily other clefts, but there can be other medical problems which we know can give rise to an increased risk to somebody having a cleft, and that's what we're looking for when we draw these family trees. And for the majority of people with a cleft that come to a genetics clinic, will not find anything else in the family. It will be one of these isolated situations, and all we'll be doing is giving that advice that, healthy living before trying for a baby, and that quoting that kind of 1 in 50 chance of them having a baby with a cleft. For others, we may identify that either the person themselves has had other medical problems that we know are associated with their cleft, or that somebody else in the family has got an associated medical problem. And that might give us a clue to which particular genetic disorder is running in that family. We would then discuss whether we could do genetic tests or not to confirm that diagnosis, and if we confirm the diagnosis, what options would be available to them when it comes to planning their own families. So there's quite a lot that can be done in a genetics clinic, but for by far the majority, it's really a reassuring appointment.
And so you mentioned as well, like some genetic tests just before. What sort of, are they the form of a blood test? Or?
They're usually blood tests. Occasionally we can do them on saliva if somebody is very averse to having needles, and quite often, children who have grown to adults that had treatment for the cleft throughout their life are kind of a bit averse to having further procedures done. So we can use saliva samples in some occasions. There's a difference between looking for alterations in genes and alterations in the chromosomes. I didn't say earlier, but the chromosomes are the packages that genes are carried on. And if we want to look for an alteration in chromosomes, which might include several different genes being involved, we need a blood sample for that. But if it's for looking at a single gene, we can do that in a saliva sample.
Oh, sorry, I have a question for Margo actually. I'm just thinking something. So sometimes when I've seen people who want to be referred to genetics, they've asked about particular things that they would be scared to find out. So not necessarily about a cleft, but I've seen people who've recently had someone in the family diagnosed with something like Huntington's. What would you be looking at in that case? Can people specify and tell you about things that they're particularly worried about finding? What should people know in advance?
If they told us during the consultation that they had, say, a grandmother who had Huntington's, we would then say to them, would they like us to look into that further?
Yeah.
If they say no at that point,
yeah,
that's the end of the story. And if they would like us to look into it further, we would then have a discussion about Huntington's and how it's inherited. So it would be very much led by them. And similarly, if we saw something else in the family that alerted us to there possibly being a problem, we would ask them, is that something they were worried about? And they might say, should I be worried about it? And say, well, we could look into it, but if you're not worried about it, we don't need to. So.
Yeah, thank you. Interesting.
And obviously within the Cleft team, genetic counselling is a little bit different to some of the other services because it's the geneticist isn't necessarily someone who you will have seen before. How does someone go about letting the Cleft team know that this is something that is important to them?
It can be as simple as that, really. Just let one of us know. So it doesn't really matter who you are talking to in the Cleft team or who you already know in the Cleft team, or if you don't actually know anyone in the Cleft team yet. So for some people, they might not be wanting to re-access Cleft services for any further treatment, but this is something on their mind. But look on the Clapper website about your Cleft team and say it's the geneticist you want to speak to. But otherwise, if you are already in a team, talk to anybody who you're seeing, whether that's the dentist, the speech therapist, the psychologist. Ask us, and as Margo was saying as well, you can talk to your GP as well if you're not sure who your Cleft team is or don't want to get involved through that route. But by covering the basis of your GP and also your Cleft team, whether you know them or not yet, they should between them be able to put you in contact with the right people who can get that kind of appointment for you.
Excellent.
Sometimes we get referrals from the antenatal clinic, so somebody's already pregnant and then has become worried. It would be much better if people did get organised and asked to be seen prior to becoming pregnant, in case there are options that we would be able to offer them.
Yeah, excellent. So now one of the things that certainly came up on the roadshow and a little bit in the survey is a situation where people perhaps hadn't thought so much about genetic counselling or hadn't been aware it was available, and really it was a bit of a shock to them at the point where they found out antenatally that their child was going to be born with a cleft. Assuming that happens, what options would be available to somebody at that point?
So is that in the antenatal part or in the genetic consultation?
Yeah, so assuming, like at the 20-week scan, someone's had a diagnosis, what support and things would be available?
So usually, I think the case is that if somebody is diagnosed antenatally with a cleft, that every Cleft team in the UK will put them in touch with the Cleft nurse, the clinical nurse specialists in the Cleft team at that point. And it's quite a normal part of the clinical nurse specialist's role in our teams to provide the kind of early counselling about that. For most people, as you've said, it is a bit of a shock and can be upsetting for some people. And in every team, as far as I'm aware, if somebody feels like they would like to explore that further, they can also be referred to one of the clinical psychologists in the team who can spend a bit more time talking about the feelings and maybe offer a bit of a longer appointment than the clinical nurse specialist might be able to. So it's really, hopefully we'll have support from the nurses, and also you can get in touch with the clinical psychologists if you think that actually having more time to talk about it would be helpful. So the main 2 points that we can support with that happening if it's upsetting for people.
Excellent. And I think it's important for people to be aware of, because it's a slightly different situation, I think, to that typical sort of antenatal diagnosis where people are obviously getting given a lot of information on cleft, where obviously if that's your background yourself, you know that, but that kind of unique position of, I've heard people discuss sort of feelings of, perhaps guilt or blame or responsibility or ownership, all those sorts of emotions that come into it, which obviously requires a slightly different discussion.
I mean, it's interesting because I'd say what we most see and recognise as a team is that it varies to people how it means. So I've, on the other hand, seen people who said, well, I'm the best possible parent for this child because I know this like the back of my hand. So some people will find that upsetting and might want further support about that. For other people, that won't be something that they're particularly bothered by, even if it was a surprise. So that's a conversation that the nurse specialist would be having with people at that time. And if it feels that it is very difficult for people, they're likely to be to have it suggested that they could come and talk to one of us as the clinical psychologists. But anybody who is in that situation, you will not be the first person to have been upset by that situation. The nurse will have had that conversation with other people before, and it's an understandable response. So don't feel that there's something wrong with you or that you just can't handle things like other people can. It's a very normal response to getting big news that changes the picture of what you thought was going to happen in your head. So please don't beat yourself up about feeling that that's a big and difficult piece of news for you to hear.
Okay, you might have answered this question, but I'm going to put it out there anyway. I imagine that one of the hopes that people undergo genetic testing is to discover that they have a very low likelihood of passing on cleft. However, if my partner and I found out we had a 1 in 4 chance, for example, of having a child with a cleft, what should we do with that information? How does it help us with our decision of whether or not to have children?
I think the thing that's central to us as clinical psychologists working in the cleft team in any situation is to think about and encourage people to think about what having a cleft means to them. So in the earlier example, if a cleft is going to mean something slightly different to every individual. So for some people, it might be that their cleft was not something that they considered a big deal at all. So it might not be something that feels like a particularly big deal to find out about. But I think the most important thing for people to think about and maybe talk to each other about and potentially talk to other people in the cleft team about is what is the meaning to you of your child potentially having a cleft. I think it's sometimes particularly difficult for people who having a cleft themselves was very difficult, and hearing that news, some people will envision their child having exactly the same experience of them. And I suppose for us that's significant because it suggests that the parent might be living with very negative feelings attached to having a cleft. So for partners to talk to each other is helpful. Sometimes people find it's helpful. I do myself with my partner about things. If it's a decision that affects both of us and we see it from different perspectives, find a friend or somebody else you can talk to independently from your partner. But in terms of what to do next and how to think about it and how it affects your decisions and how you'll handle it, it's going to be very individual to what having a cleft and what your child having a cleft means to you. That will vary from person to person.
Yeah.
Of course. I'm going to come back to you, Margo, for this next one. So let's imagine that somebody in my family had a cleft. Perhaps my mum, dad, a brother, a sister, or cousin had been born with a cleft. What would that mean, assuming that I didn't have a cleft, what would that mean for my future children? Are they at an increased risk of having a cleft?
You would be at slightly increased risk over the population risk. Obviously, the closer in relation to the person with the cleft you are, a first-degree relative is going to be higher than a second-degree relative. So for a parent who's got a cleft themselves, or it has already a parent without a cleft who's had a child with a cleft, then that's where that 1 in 50 chance comes in. And the further you get from these relationships, the lower the risk is going to be until you approach that population risk of 1 in 700. So generally we would be reassuring if it's not a first-degree relative.
Definitely, that sounds like one of the big things about genetic counselling is kind of this role in reassuring people, and sort of counselling them through that as well.
Yes, because I think a lot of people come along to genetics clinic thinking the risk is very high, and then as soon as we tell them that it's low, you can see their kind of shoulders going down in a side.
Like a bit of reassurance, yeah.
Definitely.
Okay, this is another one for you, Margo. So, let's imagine my partner had been born with a cleft. How likely is it our children will be born with a cleft?
That's that 1 in 50
Yeah.
chance, the 2% chance.
Mm-hmm.
But turning it round the other way,
Yeah.
98% of the time it's not going to happen.
Yeah.
And it would be a case of putting that in perspective of your chance of having a child with any other medical problem.
Do we know what the chances are if both parents have a cleft? Is that something that...
It's about 1 in 10 when both have got a cleft, or if a parent has a cleft and then has a child with a cleft, then the chance of having a second child with a cleft is about 1 in 10 as well. But 9 times out of 10, it's not going to happen.
And and like we were saying before, all those other conditions that we don't worry about, that have very similar.
Same risk as the rest of the population.
And finally, I'm going to come back to you, Jess, for this one. And you sort of asked us a little bit earlier, but just to sort of dig down a little bit deeper. So obviously in Nicky's scenario before, where the partner had been born with a cleft and was unsure whether they wanted to have children, perhaps to their concern, but like you were saying, that they didn't want their child to go through what they had gone through, that you as the partner did indeed want children. I imagine that can be a very tricky thing for a lot of couples. What would you recommend that Nicky do to support her partner, but whilst also making sure that her own wishes were heard and respected?
I think that's a really good question, and I think it's... I've spoken to a lot of partners of people with a cleft who, to them, it can be quite frustrating that they do not see their partner's cleft as an issue to them. So in terms of when sometimes people with a cleft will say it's the social part of having a cleft that's difficult, and that can be quite hard for partners to hear when they're thinking, I love you, it's not been an issue to me. So it can feel quite a personal issue to partners actually to hear that the cleft is still something that bothers someone when they themselves don't think it should be a significant part of their life. As I said, if you're a partner, and indeed if you are somebody with a cleft, sometimes talking to each other about the answers only gets about the situation only gets you so far. If you're not seeing eye to eye on things, sometimes it can be helpful to talk to somebody else, talk to a third party about it, because I think it can be very difficult to talk about an issue that's personal to both of you, that you both see from different sides on. And it is something that if there are two prospective partners and this is something that's difficult for them, in the cleft team as psychologists and as nurses, while we are technically there for the patients, it would be very welcome to have partners come with the people with a cleft as well to talk about these things, and sometimes having kind of talking to the team and having a third party in there facilitating that conversation can feel a bit more comfortable for people and can give you kind of suggestions as to what kind of things to think about, other questions, what are the other underlying issues here. Is it about the fear that something's going to be the same for the child as it was for the parent, which as lots of anybody I imagine with children knows, you can't imagine what your child's life is going to be like. Even if you think you can picture it, there are lots of things that might make it different. And so we would be happy as the psychologists in the cleft team, the nurses would be happy as well to have conversations with people. But if you're a partner, yes, you are a significant part of that party. I'd also say that a lot of who I see asking about genetics are people who don't actually necessarily have partners yet, that just want to know this information for their own, just to know. And so you can access the genetics service connected to the cleft team or in your local area. If you don't have a partner, you don't have to be imminently thinking about having children. It can be a hypothetical thing. And again, if that conjures up similar feelings for you, but feeling quite tricky to hear the answer, we would be happy to talk to you about the possibility of it, even if it wasn't going to happen. We don't require people to actually be having to make a decision about having children in the next couple of months to think it's worth talking about.
Of course, and I think, from what you were saying before as well, Margo, going through this process earlier rather than at that sort of point where, you're becoming pregnant.
You have to make decisions kind of quickly. And it's or it's going to come as a shock to you.
And I think some people would prefer to go to an appointment alone. Some people would prefer to go with partners, and you will see people if they go by themselves.
We see whole families or individuals as well.
Some people brought their sister along before because she wanted to know as well.
We might see them back with the partner afterwards if the person has come on their own and saying there's a kind of conflict of what they think they should be doing. And what I've seen in the genetics clinic is the person with the cleft or whatever other medical problem it is says, but if we had a child with that, I would feel guilty that it was me, that you have to explain that you've got no control over your genes, that you pass on, and that everybody's got a chance of having a child with a medical problem, even though they didn't have a health problem themselves to start with. So again, it's reassurance, it's needed.
Definitely, and because that's certainly something we hear a lot, is that kind of people are worried that they might feel guilt or that they might be blamed, and I think a lot of that's people's own perception in themselves as opposed to anything that's coming from their family or certainly not. I've never actually heard that come from a partner of anybody. But I think it's really good to know that these services are available for people and that they can go along with their partner if that's what they feel is appropriate for them as well, because these are not, none of this is easy sort of stuff for people.
No, it's not, and it's going to be different for every person, who they feel most comfortable going with, how they want to deal with that information. But think about the kind of people who you like speaking to, who you turn to for support about other problems as well. And actually, I suppose other people say it's helpful to talk to other people who have a cleft who've been in the same position. And I know that lots of our patients are now familiar with the Clapper Adult Services. And some people have said that's a really nice place to discuss is people who were in exactly the same situation, because it's a very niche situation to be in. And sometimes, even if it doesn't lead to kind of the answer, it can be really helpful to talk to someone who knows exactly where you're coming from.
And I think just having spoken about it helps as well. A lot of these people have been bottling it up for all their life, probably, their concerns about having children, and then just to be able to speak to other people who are in the same situation, or an independent person who's not in the same situation, who can see it from a completely different perspective than their own.
It's something that I hear over and over again in my role as a psychologist in the Cleft team, that people feel isolated and that they're the only person. And I think it's easy for us to lose perspective of that in the team, because day in, day out, all I see are people who have cleft. I don't meet anyone in my job who doesn't have a cleft. And other than saying just hang around in the waiting room a bit longer, people go to, if you think it would be helpful to get in touch with somebody to know that you're not on your own, whether it's about genetics or anything else. I think CLAP is something that we always encourage people to go towards.
Definitely. There's a lot of solidarity in those groups there, and shared experiences.
So that's all we've got time for on the panel discussion this month. We hope that you have found this discussion to be useful and interesting.
And remember that you can access more information and listen again to this and other panel discussions on our website at www.clapper.com/adult services project.
If this discussion has made you wish to seek support or undergo genetic counselling, please contact your GP and request a referral to the Cleft team. You will find the details of your local team on our website.
I'd like to really thank our panellists Jess, Hare and Margo Whiteford here in Scotland for joining us for today's discussion, as well as a big thank you to you at home for joining us as well.
If you want to find out more about genetics or many of the other topics featured in the Cleft Talk, we'd love for you to come and join us at the Adults Conference here in Glasgow on Saturday the 14th of September. It promises to be an informative and enjoyable day. Find out more and secure your place today by visiting our website at www.clapper.com/AC2019. And
rather fittingly, we're just discussing obviously all the things, decisions within relationships, so make sure to join us again next month when we'll be in Bristol discussing friendships and romantic relationships. Promises to be an interesting one. Until then, bye-bye for now.
Hey guys, thanks for tuning in. We want to know what you thought of the programme so that we can make it even better for the next one.
So go ahead and give the video a podcast a like, and if you're watching the video, comment below and let us know what you think. If this was interesting, make sure you subscribe to our podcast and videos.
Our next podcast and video is coming up at the end of the month, so check out www.clapper.com/panel discussions to find out what we'll be talking about next. You can also watch this and other panel discussions again on our website.
We want your questions to take to the panel. Visit our panel discussion page on our website to submit your questions.
You can also check out everything we're up to with the Adult Services Project, including a list of our upcoming programmes and events at www.kappa.com/adultservicesproject.
And make sure to also follow us on Twitter and Facebook. We look forward to seeing you again soon. Bye for now.
Bye!